almost all of our patients will have some form of prophylaxis for VOD, but you always want to be aware of identifying this condition with a higher index of suspicion in patients who have risk factors. And some of those may include, obviously, if the patient has a history of prior liver or lung disease, maybe they had viral hepatitis in the past, or maybe they have some underlying, lung disease, whether it's COPD or some other lung condition that leads to reduced lung diffusion capacity. Those are higher risks in the patient. Other patient-specific factors that have been associated with VOD include older age, poor performance status at baseline going into the transplant. And then there are the transplant-related factors, namely their conditioning regimen. Patients who have myeloablative conditioning, particularly with certain alkylators, a typical one might be busulfan, that can also increase the risk of VOD. Also, prior treatment, such as the antibody drug conjugate gemtuzumab, is known to increase the risk of VOD, and that is something to potentially avoid or just be aware of if the patient has received gemtuzumab proximal to their transplant. And there are also certain other, graft-versus-host-disease prophylactic agents that can be associated with increased risk. So those are the things you want to consider in managing a patient following their stem cell transplant in the immediate period when you're concerned about a patient potentially having VOD and considering those risk factors. VOD is actually the most common cause of death in the post-transplant period, more so than graft-versus-host-disease. So all of our patients, so it's important to be knowledgeable about this and try to prevent as well as treat it. So all of our patients go on prophylaxis with ursodiol, and they'll stay on that for about 60 days after their transplant, just for continued prophylaxis. So that is the main preventative agent. You can obviously, try to modify some of the risks. For example, we talked about gemtuzumab, maybe avoiding that if you can prior to stem cell transplant. Optimizing their medications to avoid hepatotoxic medications, making sure they don't have any untreated, liver conditions such as hepatitis. So you can try to modify those risk factors, but the mainstay of prevention is giving ursodiol starting from day 0 of their transplant. In terms of treatment, so the standard of care to treat VOD is using defibrotide, and some organizations stratify patients into mild or moderate or severe based on the degree of symptoms and organ dysfunction, but you really want to intervene as early as possible, whether they're mild or more advanced. And the mainstay of treatment is using defibrotide, and also, again, giving supportive measures to avoid volume overload and minimize unnecessary medications that may also impair liver function. So that is the typical management of VOD. Now, if patients are refractory to defibrotide for more advanced VOD, there really isn't a standard of care, but some societies say to give steroids in that setting. But defibrotide is really the mainstay of treatment for VOD.